This is Sg2 Perspectives, a conversation with Sg2 experts and industry thought leaders about the biggest trends in healthcare and what we expect that's going to mean for the future of healthcare delivery.
If we have more of a comprehensive multimodal pain management program that is standardized and we know how to troubleshoot it with our patients, we can free up our providers' time from that aspect. And it's also a big part of the outpatient shift or shift to ambulatory surgery centers from a procedural standpoint.
Welcome to Sg2 Perspectives. I'm your host, Trevor DaRin. Today I have three experts joining me. What a treat from our all service line and subject matter experts from across Intel, voices you already know and love, Kate Zentner, Justin Cassidy, and Donnelle Jageman. We're going to talk about pain management. There's a lot of corresponding content that they've created recently you can find on sg2.com. We'll link to it in the description. But I wanted to get them here to tell the story because in hearing and seeing and reading this for the first time, hearing them talk about how pain management and pain in general is a front door to so many services in the health system helped me understand the scale here and why it's such an important topic. Thanks so much for joining. I'm going to ask each of you to set up a quick summary. Like, what are the opportunities and challenges? Why is now a good time to talk about this? Why is pain management such a big deal? Kate, how about you start?
There's been a lot of focus on pain management over the years, but it's evolved. From a programmatic perspective, we still see a lot of demand, and we get a question on pain every month or so, at least from one of our members. Sometimes they're asking about what comprehensive pain should look like. What that actually means when we dig in with them, though, tends to vary a lot. And I think just as often, they're struggling to even define what pain management looks like. There's been a lot of challenges with that. There are some very obvious areas, whether it's spine or perioperative pain, that are a little bit more cohesive, a bit easier to identify. Programs now are really ready to go beyond that. In order to do so, they're going to need a more refined, more quantitative way of even getting their arms around how we define the things. Right now, that is probably the biggest focus and the biggest challenge that our health systems that we're working with are asking about in this space.
In addition, last January, suzetrigine, which is a new non-opioid pain medication, was approved for general use for acute pain management by the FDA. It came on the market. That was big news in the area of pain management. We weren't sure how this was going to impact pain patients or folks that are experiencing acute surgical pain. It is in an oral format, and we've also for many, many years been dealing with the opioid crisis. And this was thought that it might relieve some need for opioid use in pain management. That definitely piqued our interest and was one of the reasons why we wanted to look into acute pain management specifically.
Trevor, in my mind, it's all about the business of pharmacy. Case in point, talking to a large academic health system on the West Coast earlier this week, they're no longer making money on inpatient tertiary procedural services. And they're actually cross-subsidizing that enterprise with ambulatory services like pharmaceutical management. And so any sort of new innovation in pharmacy can perhaps yield more revenue for the bottom line to sustain the mission of our members. As we look to that shift, I think another great statistic is Kaufman Hall had a blog post a couple months ago saying that 60% of system revenue is now in the ambulatory space. We furthered this estimate with ambulatory revenue, and about a quarter of ambulatory revenue at least is from pharmacy. And that's equivalent, by the way, to ambulatory procedures. Thinking about strategic planning, you're thinking about not only ambulatory procedures, but pharmacy as well. And this is a big opportunity. On the inpatient, perhaps a little bit different in terms of cost cutting. On the outpatient, all about expanding access.
That's a great setup and framing. Kate, start with a little of the backstory. Give us a lay of the land. How do systems organize pain management today? I certainly haven't heard of it as a service line. What care families are impacted most? Give us the rundown.
Sure, Trevor. And you're exactly right. We typically don't see it defined as a distinct service line, in part because pain is so pervasive and because it does overlap across so many clinical areas. There has been defined targeted work on some specific things, though. Obviously, opioid stewardship has been a big one over the last decade, where we saw that big pendulum swing from not nearly enough regulation to perhaps overinterpretation of guidelines towards back to where a little bit of that has normalized out. Along with that, we've seen develop some specific programs around perioperative management. Think enhanced recovery after surgery protocols for things like colorectal, complex spine surgery. Spine and back pain management sometimes will be its own center, since that is such a large patient population. Musculoskeletal could be a part of that as well. And then the other one I always like to call out, this isn't covering everything, by the way, it's just a few highlights, would be cancer pain. Typically, cancer is managed separately from all the other types of pain because there are going to be different considerations, things like opioid avoidance that are a little bit different for that population. And because there is such a high need, that typically is something where you will see better developed infrastructure as well. Once we go beyond that, though, to comprehensive pain that's non-cancer, non-back pain related, non-musculoskeletal, this is where things begin to get more amorphous. Historically, programs have only been able to define it more based around the specialist and where they may have interests and capabilities beyond those things. But what our belief is that now if programs do want to get beyond that, they probably need a more methodical way to figure out what are those cross-service line opportunities and areas where we need to build bridges with pharmacy, interventional pain, all these specialists that are going to need to require a little bit more overlap, perhaps between programs, if that makes sense.
Our analysis did reveal what we already know and what Kate mentioned. A lot of pain, especially for inpatients, is related to the spine care family. 4 out of the top 5 most painful care families, as we define them in our analysis, were actually associated with spine service line patients. When we look at outpatient or ambulatory, defining pain there, the top care family was general medicine's acute pain care family within Sg2. So validating that acute pain turned out to be the number 1 in our acute pain analysis. But we saw spine and orthopedics come to the top in the most painful care families on outpatient too, where the majority of patients, over 75%, are using an opioid as an outpatient.
Donnelle, I think you raise a great point with the care families most impacted. It's also interesting, our analysis uncovered many care families that are not as impacted by pain management, but could perhaps benefit more, many in behavioral health in particular. Overall, our analysis was striking in that almost every care family is impacted. Every care family has some degree of pain management need. That multidisciplinary focus is important. And as we look to the traditional areas, both you and Kate just mentioned, of programmatic focus, there's a lot of unmet opportunity across service lines. While systems have organized pain management under those areas of highest need traditionally, there might be a need or a benefit to a more comprehensive pain management approach that pharmacists led across the entire system of care. That's kind of number one. The other is, as we think about pain points, particularly as it relates to opioid stewardship programs, we thought that this was still arduous, but when we interviewed 15, 20 clinical pharmacists for this work, it turned out that the protocols are not as arduous as they had been. Usually it's just a couple clicks when filling a script to check and ensure that a patient qualifies. And so it wasn't as much of a pain point as in the past. And in fact, when we looked at opioid use rates with our data over time, they're flat. Given rising patient acuity, increasing comorbidity and complexity, we actually think there might be an opportunity to expand appropriate pain management to increase that rate a little bit. The other sort of pain points here as we look at that entirety of the system of care, that cross-service line and care family opportunity, is that this is a patient satisfier. Pain drives folks into care and it helps patients get answers and therapy earlier. The revenue generating potential is significant. It can enable access by unlocking subspecialist time within those various subspecialties impacted with a more general protocol. There's also this innovation that's already here, as Donnelle mentioned, but going to be increasing. There's a recognition that pain, like every medical condition, has different subtypes, and treating the actual molecular cause of pain, when identified, is going to yield more effective therapy, this sort of precision pain management. And so pharma is taking that basic research to the next step. Many drugs are in the pipeline for approval, and this is only going to be more of a need later on. Exciting innovations here. So to address these pain points, we realized that there need to be integrated insights that develop actionable intelligence. In this case, integrated insights from our Impact of Change forecast, our Sg2 Care Grouper, the clinical database at Vizient, and Medicare Innovator Part D data that actually identifies pharmacy claims. On the inpatient side, we were able to see for each discharge of patients in the CDB, whether or not they used an opioid for acute pain management. And in that case, that percent of pain management that was used per patient in the inpatient side was used to define that relative frequency of pain management per each individual care family or procedure that we analyzed. On the outpatient side, using Medicare Innovator or Part D data, we looked at any opioid that was prescribed over the last calendar year for each of those individual care families. And so this gives us a really nice picture of whether or not the patient was receiving care for pain. The pervasiveness of it across all conditions speaks to the universality of it and the opportunity to unlock access with a more centralized pain management program.
Thanks. Just hearing you guys talk about it, my spine hurts right now. Donnelle, I understand there's also a corresponding policy change here. It's not the primary driver here of why systems need to change, but it could accelerate or create a new pathway for patients. Talk about that, please.
The No Pain Act, which is Non-Opioids Prevent Addiction in the nation, is the relevant policy here. It was actually signed into law in December of 2022. It permits additional reimbursement temporarily for devices and pharmaceuticals that are non-opioid methodologies for pain management. So that's where we see suzetrigine, the new non-opioid oral, fall under, hoping that they'll be included in that. Right now, there's 5 drugs and actually 11 devices that qualify for that temporary additional reimbursement in the hospital side and for ASCs. Originally, it was just for ambulatory surgery centers to make sure that, given the lower reimbursement levels, there was still incentive to use non-opioid pain management there. That has encouraged non-opioid pain management innovation, one being suzetrigine, like we've mentioned. And then there's other innovations that haven't fallen under that No Pain Act yet. We are seeing the use of ketamine for chronic pain, and for other chronic pain like diabetic neuropathy, we're seeing the use of spinal cord stimulation for pain management as well.
All right, Justin, so take this down to like a practical health system level. Where does pain management live across the system of care? Like, who really interacts with it? Where is it making the biggest impact?
If you look at acute pain management, I'd say the single largest bolus, it's at the office, but also urgent care, intermediate care clinics. There's a lot of volumes there on the outpatient side. On the inpatient side, it's interesting. There's actually the greatest need for pain management in care families and conditions that we might not typically consider to have high pain prioritization. So think of spine and so on. It makes the minority of inpatient discharges, but the need for pain management within medical conditions is actually greater. The sort of breakout of those medical conditions, relative frequency of pain management is about 62% of the time inpatient. So basically, given any sort of discharge, it would be more often than not a medical admission that is receiving pain management, which might be surprising. The sort of high need pain management is about 12% of all prescribing activity in the inpatient side. What's super surprising is the pain management is happening at every site across the system of care. There's a lot of post-acute care pain management at SNFs and home. In fact, the greatest percentage of high pain management need is in those locations. Not surprising given the recovery. What's interesting is that virtual has a very high percent of ongoing pain management for patients with the highest needs for acute pain management. So that perioperative recovery is often being managed in the virtual side of care at this point in time. As we look to the forecast, the single greatest growth opportunity also is in the virtual setting. This is really great news for health systems, again, looking to unlock access. Thinking about multifaceted strategies in which to do so. Virtual health can be a real enabler. It perhaps was something that they were reticent to do when opioids were the only option, but now with new precision pain management meds, this may be opening new doors for pharmaceutical access.
And Justin, it's interesting to hear and have seen all of this through the analysis as well. We have seen, as most folks are probably aware, a little bit of a drop-off in virtual health. One of the few specialties where we've seen some data across specialists that shows increases still going on, it's the pain specialist. That's reflective there as well.
That's great. Lots of good nuggets, new analyses, new findings. I want a summary from each of you of the big thing you're paying attention to, where you think this is going to make an impact, how might it change care delivery, where are you focused going forward? Donnelle, why don't you start?
Orthopedics is my world at Sg2, so I think in terms of orthopedic and spine patients primarily. And pain management can be very onerous for our orthopedic surgeons, especially when we have patients that get sent home post-operatively that need continual pain management. Dealing with that follow-up care can be extremely time-consuming and limit capacity for our surgeons. Imagine you discharge someone with their knee replacement and they go home with an opioid and it makes them nauseous and they have other side effects. You have to see them again, bring them in, find a different way to take care of them. If we have more of a comprehensive multimodal pain management program that is standardized and we know how to troubleshoot it with our patients, we can free up our providers' time from that aspect. And it's also a big part of the outpatient shift or shift to ambulatory surgery centers from a procedural standpoint. the better we can manage patients' pain, the faster they can go home. And we've seen things like nerve blocks and epidurals really help transition to ambulatory sites of care for surgery. So that pain management element can decrease length of stay and get people home the same day too.
If I had one recommendation for health systems, I learned from this analysis related to that stratification of high, medium, or low pain management need. What was most interesting to me was not necessarily the high utilizers, because acute pain, perioperative, all the spine care families that showed up there, those are the obvious ones where you may already have a lot of infrastructure. If not, that's a great target. It's that messy middle going to be growing fastest in the outpatient space, where I believe there's probably a lot of opportunity where these folks may not always need pain, but it's worth it to build infrastructure so that it's easy for them to get it. Those relationships are already there when they need it. We saw things like musculoskeletal pain that you might expect, but also mood disorders, multiple sclerosis, that speaks to this idea of the need for interdisciplinary collaboration, whether it's pharmacy, pain specialists, behavioral health even. There's a lot to learn from applying these sorts of integrated analyses to your market, to your health system, to understand what kind of collaboration is necessary and what your best targets as you're looking to move beyond the 1.0, 2.0 version of your program really should be.
This is a revenue opportunity. Number one, don't ignore that. As we think about 2026, access is going to be the word of the year for health systems. And we've already done a really good job on the inpatient side. The inpatient equivalent to access hurdles on the outpatient side is capacity crunch. Systems have gotten out of this. But it wasn't one single silver magic bullet. It was multiple initiatives being enacted side by side, and no one's doing them all. So systems have made significant progress in unlocking that access to be able to serve patients with procedural needs. In outpatient, you have to do the same. You have to identify areas of clinical need that overlap across subspecialist care, like comprehensive pain management. And Kate, to your point, that intermediate bucket, really intriguing, includes a lot of proceduralist specialties like cardiology. If you're looking to grow those programs, usually the rate limiter is proceduralist recruitment. And if there's a high percentage of visits that are for pain management, that detracts from the provider's time. It could be better spent on working to the top of their license doing procedural activity. I'd also double down the low acuity, the lower need. It's just the total pain management. There's just the highest volumes there. If you're going to move the needle on scale and unlock some specialist access, this is a great place to start. It's actionable intelligence. Give this to your comprehensive pain management program leaders and say, you might be able to use this to identify the greatest patient bolus to, if you're going to build an embedded program in a specific area, where might that be if it's not obvious perioperative management?
Thanks so much to all three of you. I love when we get to go deep on a topic, hear a few different perspectives from different areas of subject matter expertise. This was great. Thanks so much for sharing your perspective with our listeners. Thanks for listening. If you like this episode, please subscribe, rate, and review us, and/or follow us on Twitter and LinkedIn at Sg2 Healthcare. And if you want to talk more about innovative healthcare strategies, you can always email me at sg2perspectives@sg2.com. Finally, Sg2 is a Vizient company, and there are a bunch of Vizient podcasts that you might like. You could find them at Vizient /podcasts. Have a great day.